Good morning and welcome to Trauma Grand Rounds. My name is Courtney Herron and I am the Trauma Services Educator. There is no commercial support for today's program. The speakers and planners have disclosed no relevant financial relationships with commercial interest. For successful completion of this learning activity, learners must attend the complete activity for CE credit with no partial credit available. If you have any questions for the presenters, please hold the Q&A segment at the end of this talk. If you are attending virtually and you have questions, please enter it into the Q&A section. Also, a link in the event survey will be shared at the end of the program. I wanted to give a little background information on why I chose ethical decision making as a topic for today's Trauma Grand Rounds. My team and I were going through some data and we decided to kind of target advanced directives and learn a little bit more about that so we could better understand it ourselves, to better understand and educate our patients. And we ended up meeting with individuals in the hospital and we learned very quickly that our understanding of advanced directives and decision making was very limited. So with that, our population that we serve, many of you guys know that a lot of times they are not necessarily equipped to handle the harsh realities of what their traumatic event may handle. So as healthcare providers, I want to empower and encourage you guys to be able to not only empower our patients, but to be able to give them a choice in their life and their death. So I'm going to go ahead and turn it over to our panelists, and they are going to introduce themselves and what their role is. We'll get started with a short case scenario, and then we'll open it up to question and answers.
My name is Hellen Ransom. I'm the clinical ethicist for the system.
Morning, my name is Kim Kottemann. I'm the Director of Professional Programs and Transplant Center Relations for LifeLink of Georgia. So I work very closely with Tisha Campbell, who you guys probably all know. She cannot be here today. Unfortunately, she was contracted to maybe dial in for a minute. But I work very closely with all of our hospital development liaisons on kind of integration of donation into all types of systems. So we do a lot of work with trauma and we do a lot of work with palliative care and hospice. So this is really a perfect fit for us. So thank you for including us. I'm Dr. Mary Keith. I'm the Hospice Medical Director for Hospice of Northeast Georgia. And as such, I'm also a hospice physician who sees our inpatient hospice patients, home patients, and then takes care of our in-home palliative care patients as well.
I'm Libby Dunahoo. I'm the manager of advanced care planning. My team is the one that goes around and makes sure that patients have an advanced directive or know how to make those choices if they want to, and know who that legal medical surrogate is if they're not doing an advanced directive. With our case, wanted to present a case that gave each of us maybe an opportunity to, again, highlight the need for conversations surrounding advanced directives and what to do in certain situations. So this was a case, this case is based on, of course, a real case, had to change names and everything. So entitled is A Man of Faith, Determining End of Life Wishes when no directives, are available. We did the financial disclosures. We have nothing. There are no commercial support that neither of us have to disclose. Again, objectives. We want to examine how beliefs, ethics, and the law are applied to end-of-life case. I describe how different patient preferences regarding end-of-life treatments can be applied in this specific case, and also not just in this case, but can lean itself to other cases that you may encounter, and also identify the role in physician-patient conversation, but not just physician-patient conversation, but physician or practitioner, nurse, family, friend, whoever you're in front of conversation. The importance of the conversation, that will be the overarching theme, thread, anchor for today's presentation. So let's get into our case. So we have JW, who was admitted because of has a history of chronic deep vein thrombosis, who was generally avoidant of medical care, kind of like a lot of our patients that we encounter. His friend spoke with a chaplain yesterday
presented to our Gainesville Hospital with acute metabolic and see, this is where I would need, encephalopathy. So, this is where we need, good young persons, jaundice and abnormal liver function test. CT of abdomen and pelvis demonstrated severe, and see, this is where...
Intrahepatic biliary dilatation.
And what...
And a mass at the porta hepatis.
And what exactly, for those of us who are not... we're clinical, but not clinical enough. What exactly does that mean?
There's some obstruction.
There's some obstruction. It's severe obstruction,
yes.
I'm imagining. Okay. And we have the measurements there, and, dealing with that size, is that pretty significant?
Yes.
Okay. Now, this was suspected to be a gallbladder mass, and he initially was on heated high-flow nasal cannula. Condition quickly deteriorated, and he was intubated. He was also required for a CRRT, which is ongoing. Now, again, this is where I turn to...
that's just continuous dialysis.
Okay. Now, discussions was held with family, and we're using the word family kind of loosely in this conversation. By the critical care team indicated that they would not want long-term ventilator management with a trach. And there was tentative plan to review the case a few days later to discuss comfort care if he had not yet graduated off the ventilator. And this is pretty standard par for course as far as, to try something, see if it works, give it a few days, see where things go. So that's what, of course, continued. And as the days continued, critical care team met with the patient's closest kin. And this is again, so they met with cousins. So as you see, as the case is progressing, we're seeing now where we went from the use of the word family, closest kin, to cousins. So we're getting a little bit of clarification with the family members. At this time, we're also seeing some clarification in the treatment as well. As far as the drain placement, family decided they wanted to continue with disease-directed care to investigate, to see measures before transitioning to comfort care. So just pausing here, for those of you in attendance, just kind of like by show of hands, this is pretty much kind of what you have experienced, kind of everyone is kind of full course press, and then see, where things are going. Okay. And of note, one cousin indicated that the patient would want to fight for as long as possible. These are words that you've heard before, people wanting to fight, wanting to continue. My cousin was a fighter, wanted to, now, at this point in time, palliative was consulted to assist in a goals of care conversation. Now, palliative, and our palliative team is great. They began phone calls to cousins, starting with a cousin by the name of Justin, who stated that all cousins agreed to continue with the disease-directed care for evaluation of the mass, and could possibly change the options of care. If not, he states that they're all in agreement. There's also another cousin named Jeffrey, and the cousins who concerned that wanted indefinite ongoing disease-directed care. And again, so everybody's is in agreement. Now, as you can tell, I'm getting a little antsy and staying still. I will do so. Using the words cousin, in dealing with family, as far as talking to family, Georgia is fairly unique. We have two separate hierarchies for persons that we can talk to. Georgia has a list for persons who can make surgical and medical decisions, and we have another list for persons who can make decisions regarding resuscitation. Where do you think cousins lie on the medical and surgical list, and also for the list for resuscitation? And this is where I'm turning to the audience for a little bit of call and response.
I agree, but
Probably pretty low. Okay.
Are they behind this for resuscitation?
Okay. Are they even on the? Okay. Or maybe I should put it like this. Would you want your cousins making some decision? Okay. I see a couple of head nods of no. Okay. Okay. And so it's fairly small, but I put the two lists together. Unfortunately, cousins are not on the list. But this is something that I think we find ourselves in that predicament a lot, where we tend to deal with who's available in these conversations, you know, like who is available. And sometimes it's either the people who are at bedside, or in some circumstances, it's the person or persons who are the loudest. Kind of like this, you know, the people who are more involved are those who are more engaged in the conversation, or those who will be engaged in the conversation. So, you know, if you're the leader of the family, then you will be the one who will be leading the charge. You will, you know, and at these times, that's when I will, you know, probably, you know, turn to Libby and definitely say, we don't know, like in JW's case, did anyone pause and check to see or ask? What's that lovely question that, you know, we should maybe ask at this point in time, you know, Libby? Does he have an advance directive? Was one searched for? Did we even inquire? You know, we're having conversations about goals of care, his medical wishes. Do we have an advance directive? Did we search for an advance directive? Do we ask these cousins about an advance directive? Because when the question was asked earlier, you know, where do cousins fall? Pretty low. They're not on the list at all. Now, we do have, adult friend. So cousins can fall within the adult friend category, but we have to get through all of these, you know, as far as spouse, parent, adult child, adult siblings, grandparent, adult grandchild, adult niece, and this is the first degree. So second niece, third niece, all those kind of down the line, and nephews do not factor in. And then adult friend, which is a very useful category, especially for older adults, because, you know, kind of as we age, we tend to lose people kind of in and out of our lives, where neighbors become like family and they know more about us than anyone else. There have been several cases where neighbors and even in some cases landlords will know more about a patient than anyone else could even imagine. So this list is very helpful. But in this case, we had cousins who knew, but as far as, you know, trying to make sure that we follow our policy and Georgia law, just taking the moment to ask questions and have conversations. So I will pause here. Any other kind of moments of opportunity that were missed? Okay. Now, an important, there were two notes that highlighted aspects of JW's wishes, because that's what, we're trying to figure out, what would he want? Because at this time, he's not able to communicate anything, and we're relying on other people to give us kind of a substituted decision regarding his medical wishes, and we're relying on them to give aspects of his best wishes or best, interest. And so the pastoral, the chaplain had a conversation with one of the cousins, and in this conversation, with Luke, JW has a lot of cousins, and Justin and Amber. I think these were two primary persons who were involved in the care. JW's parents are deceased. He's not married. Again, trying to, verify that hierarchy, that list. Luke shared that JW is a man of faith, who serves as a deacon in his church, in addition to being on the finance committee. And JW is a person who's always encouraging everyone else. So getting some context as far as who JW is as a person, because while we see him at his most vulnerable state, outside of our walls here, at how is JW? What does he like to do? And so this is important context. And this note here with one of our physicians is important because it gives additional information, because there was also questions about whether or not JW had any children. And verify, again, not married, no spouse, no children. And also, while the cousins are not on the list, these cousins are very involved, very much so engaged in the conversation or engaged in his care. They care about him. And also seeing that the type of person that JW is, he works at Walmart, and people were concerned. They were looking for him. He'd not heard from him in 4 days. So this is someone who is seen as a fairly stand-up person, and his presence was missed. So these are important factors that gives a lot of context to not only the type of care that he would want, hence the title, a man of faith, but also the context to the integrity of JW as a person, which is important overall. So with the pieces that we have presented so far about the case, I guess, what are your initial concerns? So we've kind of presented a lot about JW, presented a lot about the contextual issues concerning his overall medical condition, issues presented about the cousins, issues presented regarding he's not married, no children, parents are deceased. So what are your knee-jerk reactions, initial concerns, initial thoughts and questions?
What's his prognosis?
Ooh.
Have been given any kind of prognosis?
Okay.
It's how do you know that's you're being told the truth? I'm a social worker. I'm suspicious, but
Okay.
we hear on this, and we get stories sometimes, and we have a lot of broken families, and you don't always get the truth right out. So I wonder how far do we go in possibly investigating the possibility of another relative maybe higher on hierarchy.
So clarifying the prognosis, how far down the rabbit trail do we go regarding family? How, I guess, deep do we go as far as, is this the truth? Okay. What I can recall about his prognosis is just, I just remember it being dire and not a lot of options available. Because in ethics, there's this whole thing about kind of like ordinary versus extraordinary care. And with ordinary care, meaning what are the options available to kind of sustain life and, make him comfortable. The team just really had options of kind of comfort care, extraordinary efforts available, as far as surgery or anything else. They were very limited because of the obstruction. And even though his family was saying things like, okay, he would want to fight, those options were not available to him. So, and that's kind of like, in some of the cases that I'm called into, there is this tension of the family wants everything done. And the team will say, well, the family wants everything. And I'm like, okay, well, what's the appropriate everything for this patient? And trying to do a bit of a level set, because that word everything is a bit weighty, but trying to reframe it in what's the appropriate everything for this patient, because the appropriate everything for this patient could be comfort care is the appropriate everything for this patient regarding, if you look at within the realm of ethics as far as ordinary versus extraordinary treatment. But within JW's case, the ordinary realm of treatment was the avenue that was open. As far as extraordinary options, unfortunately, those options were closed because of the obstruction and just kind of the course of the progression of the disease and how things had moved. As far as the other question, kind of how far do you go down the rabbit hole? With some things, you can't investigate everything. You have to, in some ways, take the information that's presented to you at face value. Like if a couple were to say that they're married, do you ask them for their marriage certificate? You may be tempted to. I know I've been tempted to. You may be tempted to, especially if you get one wife 1 week and another wife another week. You'd be like, hey, who's the real wife? But you just go on face value until the other wife shows up or the other husband shows up, Have to be fair in my examples here. So you just have to go at face value. Because if you kind of keep going until you're chasing that going down that rabbit hole, there will always be this sense of doubt, and that trust and communication will never be sufficient. And I know you're trying to meet patients and families where they are. So kind of have to, well, yeah, not kind of, you have to give people grace. I guess maybe until, and hopefully that until doesn't happen. Because I'm quite sure maybe in your case, it's rare, hopefully. Okay, I've seen it head nod of yes. It's rare that those cases happen, but.
The other important question would be, what the person that's on the therapy team most trusted?
Mm-hmm.
What is their engagement in transitioning to end of life? And as soon as I see MRCP, I wonder if this is one of our H2B patients that we see a lot done for them because they have successes and they have 20% survivability going into an operation. They know there's a lot of effort that's needed to achieve that 20% survivability. So what is the therapeutic driver from a physician's standpoint saying about the ability to transition to comfort is our biggest determiner from a critical care side of whether we can successfully do so, because that's the person that's met them in the office beforehand, that's shaken the family's hand beforehand, that's told them we're going to get through this beforehand, and we're coming in and saying, hey, time to throw a towel in.
Right.
That relationship is incredibly important for the therapeutic circle. And then transitioning to end of life has to almost be approved of by the clinical driver. That's above everything else, I would say, for us. That's an initial concern.
Yeah, I've had conversations with families in that same vein where they just want to hear from the cardiologist. It's like everything else is falling apart, like every other organ system. And you can try to explain that, but they're like, I need my cardiologist to come here and tell me that it's time. And it is that trusted person or that last little ray of hope. This person's always been so encouraging and has always said that we're going to fight this and we're going to get through it. And they need to hear it from that person that it's really time.
Yeah. And, having those conversations and getting everyone on board is important. And that's why, having, that's why that shared decision-making piece is on top, and making sure that we get, have the stakeholders that need to be involved in those conversations. And sometimes we do have to take a step back to look at who should be involved in conversations at certain times. And there are times when everyone needs to be involved in a conversation, and there are times when, okay, there are appropriate conversations that need to happen kind of like at a tiered approach where, okay, this team for this conversation and this team for this conversation. But that's where you have to, again, take a step back and see what's most appropriate for this patient at this particular time. And with JW, it was important to take in information from the cousins because they were most involved. I don't recall if there were a lot of questions about the cardiologist piece, but that doesn't mean that that should be something that is skipped. But as far as aspects of, if we're just looking here, making sure the aspects of probably the most important ethical principle in this whole case is beneficence. And that is, making sure that no harms and no additional harms is brought forward with JW, and not just JW, but also with his friends and his cousins, because there was so much care that there was always someone at his bedside. There was always someone surrounding him, someone who was there to provide a presence of care, because that was just the type of person he was. So we didn't want any type of additional harms to come to them and him. because of just the type of support that he had going.
So, Dr. Ransom, what information must be documented in a patient's chart before the case can be presented to NGHS's Ethics Committee for a 2-physician DNR review?
Okay, the information that must be documented in the chart, it seems like a lot of information, but I'll just start with the basics. But the basics is a lot. It's making sure that the patient, whether or not the patient has capacity, want to have documented under what criteria does the patient meet for, I guess, why resuscitation would not be recommended for the patient by 2 physicians. And what also needs to be documented is the search for family. Because in order for this to be presented to the Ethics Committee, this is for persons who do not have, one, capacity to make decisions on their own, and then for persons for whom they do not have anyone to make decisions for them. So in order for that to take place, that means that a search for family would have to be documented in the chart. Again, no capacity. And then also 2 physicians will have to document in the chart that, okay, DNR attempts would not be of benefit. And once that information is documented in the chart, I will look in the chart, present that information to the Ethics Committee, and then from there, the Ethics Committee will review, and we will take that to the Ethics Committee. They will make a review, make some notes, recommendations, and then go from there as far as the review for the 2-physician DNR.
So we need ethics to say that there's futility in resuscitative efforts?
Only if they don't have anybody in that hierarchy to
Yes.
make the decision for DNR.
And so that is for,
How does the trauma bay fit in that?
That's a good question.
how does the trauma bay fit in it?
Things are just moving much faster and
Yes.
more. Yeah. What can you give a specific example?
Codes in front of us.
Okay, well, that's it.
Yeah.
Well,
At 3 in the morning. At 3 in the morning.
at 3 in the morning.
Okay.
So I think he's at 3 in the afternoon.
Whenever you're most here,
Okay.
doesn't change the answer though.
Yeah.
We're not gonna code that patient.
Shows up in the ED, you're required to do life-sustaining
Yeah,
treatment.
For how long?
That's your clinical
That's
decision.
my point. So
That's
the
a
futility
clinic.
is determined by the physician team at the
Right.
bedside.
But if you have a patient that's just in the ICU and they're just, declining, and you're thinking they're going to code at some point, and I don't think that resuscitation is in their best interest.
Yes.
It's not going to be successful. Then you could try to get the 2 DNR. It's done very quickly during the
Yes.
daytime, obviously.
Do we need it, is my question.
To choose not to resuscitate the patient, yes.
Yes.
To start the resuscitation if they're full code and then stop it once it's unsuccessful or you've gone on for however many minutes you think it's futile at this point, then no, you would not need that because it's not a DNR. It's a full code situation with an unsuccessful resuscitation.
Consultation, yes, which is something a little different.
It's a big gray area. If somebody's on 14 pressors and full life support on a ventilator and they code, we've already been coding them for 3 days.
Right.
But
Hours without chest compressions.
and in
Yeah. I think it's the chest compressions and the shocking and like the actual going through an ACLS. Yeah, I understand your point.
Yes, and in that situation where you're saying that they've been on the pressors and things for 3 days, and if they don't have family, I would hope that, okay, if they don't have family, don't have capacity, if you're seeing that, okay, this course is going to be going on for a long time and you know that they don't have family and that's been documented, why not reach out to the ethics committee to do the physician DNR? Because what we encounter as with the ethics committee is patients who've been here for months, and then, oh, it's Friday, 5:00.
Okay.
Before the weekend. Hey, we need a 2-physician DNR. Can you get it to us in 30 minutes? And then I'm asking for the things, have they been documented in the chart? No, they haven't, but they've been here for 3 months. So it's kind of like, help me, help you. So if you see these things, kind of like with the writing on the wall, reach out. So that way we can help each other. So that way you're not in a situation frustrated at night on the weekend. If something happens on the weekend, if something happens at night, there's some times where, we can definitely make things work. As I introduced myself, I'm the clinical ethicist for the whole system. I'm the only one. But again, we can help each other in certain situations. So if you see the writing on the wall beforehand, please, this is for everybody. I don't forget who sings the song, but I think it's the Temptations. Darling, reach out, please. So that way we can be proactive in these situations, because the last thing I want is for any physician, any team member to be caught in a situation where it's Saturday and it's like, I won't say the expletive, but we are stuck. So if you see the writing on the wall and it's something where we can help in this situation, please, let's be proactive.
Libby, this question's for you. What is the difference between a legal medical surrogate and a healthcare agent?
It was someone who was proactive. and that's the whole point of this. I mean, the whole reason we're required to ask if they have an advance directive is because that's where we hear what the patient wants, right? The only way we know what the patient wants is for the patient to tell us. So the patient that doesn't have capacity, the patient that doesn't have any family, we're all wondering what would they want and what do we need to do? And how do we explain to someone what futility of care is and everything? So the whole point is naming someone in an advance directive means you don't have to pay attention to that hierarchy at all, because that patient said, I have given this authority to this person and this person knows what is quality of life to me, so that they can listen to that person on the care team that they trust, and they can say, okay, so you're telling me that this really isn't going to be quality anymore, or that 20% chance. I know I can advocate because I've had a conversation with this patient and they've trusted me to be their advocate by giving me this authority. And I know that they wouldn't want this. We end up with people having to go through the hierarchy because they haven't been able to proactively have a conversation around this. And so the whole role of advanced care planning is to push it upstream, to have the patients that we're seeing who's at the bedside. We're seeing 400 patients a month that aren't in critical care because we're trying to get them to say, hey, you're here. Whatever you're here for, next time, if you weren't able to advocate for yourself, what can you give as a gift to your family to know how to advocate for you? And who would that be? Letting the patient know. This is about patient, having someone advocate for them is for them to understand what their choices are. The clinical team is going to give them information, but then they have to take it in and go, okay, now to me, what is quality of life to me? What's worth continuing? And so having people understand who's in their legal medical surrogate order. A lot of times we're educating the patient to say, do you realize that you're not married, you don't have a legally appointed guardian, you don't have children, you don't have living parents. Okay, well, you know what? Your siblings are going to speak for you. And they're like, oh, no, I don't speak to them anymore. Or, oh, I don't speak to my children. This is my common law wife. She's absolutely speaking for me. I've already told you she's my emergency contact. That doesn't mean anything unless you've given someone that authority in an advance directive. You are subjecting the hospital to needing to use the LMS order. So we're trying to get people to have conversations sooner, to say, you know what, you get to advocate for yourself, but at the time when you can't, have someone that knows what quality of life means to you. So healthcare agent means you don't have to pay attention to the LMS order at all. You've named them in an advance directive. And it doesn't have to be family. It doesn't even have to be anybody in that order. It can be the friend, the neighbor, whoever it is.
Can I ask a question about that? Does the person that they give the directive to have to sign that document as well?
No, but we do tell people when you name someone, the conversation is more important than the document because that person has the right to refuse. And we have had someone before in the past that we've called the person, written in on their advance directive, and they're like, oh, wow, I worked with this person 20 years ago. I don't really feel comfortable making decisions for them. It's like, okay, so they had the right to refuse. So we really want the patient to understand that. Don't fill this out, go put it in a safe deposit box and never tell anybody, because then that's not going to serve you well.
And you automatically flip back to the
Legal medical surrogate order if they have not named. The advance directive allows you to name a backup and a backup to that. We've had someone name someone who was incarcerated. And I'm like, okay, we might not be able to get in touch with them 24/7. Can we have a backup? So they can do that.
Hey, Libby, can you talk about the difference of the Part A and what's the importance of the Part A versus what the actual medical wishes are?
So that's what I appreciate you asking that, because, you know, in the advance directive, the Georgia legislature combined the durable power of attorney for healthcare in Part 1 and Part 2 are those treatment preferences that were the living will. The most important part, though, is that Part 1 is you are giving that authority. That person becomes your decision maker. We don't pay attention to the LMS order. Everything in Part 2, the treatment preferences, what would you want to request or refuse? Those are suggestions. Those are guidance. It says at the first paragraph of Part 2, if you have chosen someone in Part 1, they're going to make your decisions, and this will help guide them. But not every situation can be documented in the few boxes that you check in Part 2. So in terminal illness and state of permanent unconsciousness, there's a million different things that can bring them here. Nobody was expecting a gunshot to their head at 3:00 in the afternoon. Does your advocate know what you would want in that situation? Just because you've checked a box, I would want everything. Or just because you've checked a box, I would want to allow my natural death. Different circumstances can bring people to different decisions. And so therefore, who you name in Part 1 is the most important thing that they do in an advance directive. Everything in Part 2 is to help that person. And that's why I always tell people the conversation is more important than the document, because you'll be able to tell someone, hey, I don't ever want to be intubated again. I got intubated. I never want that again. Oh, they're here for pneumonia. Actually, I know that they would want to be intubated because, you know, you guys are going to be able to extubate. They were like expressing they don't want to live on a ventilator. So people, you know, patient understanding, what's their understanding of therapeutic care versus life-sustaining care and things like that. So Part 1 becomes the most important part of naming that healthcare agent.
I also want to point out that you only have to complete Part 1 for it to be a valid document.
Yes.
So Part 2 can be left completely blank. And that's, you know, there are times where I'll sit down with a patient and they'll say, but I don't really know yet what I would want. Like, I haven't thought through this, but they do know who they would want to make decisions. Then I'll say, well, let's fill out the healthcare agent part, and then I'll just write intentionally left blank on the other pages, and it's a valid document. So they don't have to have really thought through. You know, we encourage, well, now that you've chosen your decision maker, you need to start thinking about these things and have that conversation. But if they're not ready to think through those things, that's not a reason to not complete the document. Especially if they know that their elected decision maker would be someone that's different from their hierarchy.
Exactly.
All right, Kim, this question's for you. How does organ donation fit into ethical decision making at the end of life?
So thank you. every case I think is a bit different. And so I was thinking about in this particular case, in the information that we gave, we hadn't quite got to us yet, and that's perfect. That's fine. There's really sort of two scenarios, obviously, when you're starting to think about being in an end-of-life situation. So we kind of differentiate between people who die on a ventilator and people die of cardiac arrest who are not ventilated, right? So patients on a ventilator, that early referral is more important to us because that is the opportunity to donate vital organs. So heart, lung, liver, kidney, pancreas, that patient still has to be ventilated. Once they have been cardiac dead, that's when we can talk about tissue and eye donation. So I don't want to negate that because in this type of scenario, we'd probably be talking about those potential opportunities. But it's the first scenario that's more critical for us because once you get to that DNR, once withdrawal of life-sustaining therapy happens, there's kind of no going back, if you will. And organ donation, I think it's always a difficult decision when to bring it up. And so we can help with that process. But if you don't bring it up, and we ask that you don't, but that we bring it up, that you bring us into the conversation early or into the scenario early so that we can together make a decision of when it might be most appropriate to talk to that family. So in terms of ethical decision-making, we always talk about at end of life, families or patients, as it might be, should have every opportunity that they, whatever it might be, whether it's around hospice care or whatever the end of life plans might be, that donation should be a part of that and they shouldn't be mutually exclusive. And so making sure that we're there in the conversation to make that fit when the time is right, I think is the most important part. And I'll throw in a couple of my other questions, if that's okay. Age is probably one of the first things that comes to mind. And this was a 70-year-old. We certainly do organ donation over 70 all the time. He wasn't ventilated, of course. But I will tell you that the oldest liver that has been transplanted, I think, is 94 years old. I've heard some conversation about a 97-year-old, but I haven't verified that case yet. Wow. And so my message to you guys is always don't get caught up in all of the details because make the referral based on clinical triggers, which is that the patient's on a ventilator, has a Glasgow Coma scale of 5 or less, or there is a discussion about all these things that you've been talking about. So withdrawal of life-sustaining therapy, movement to DNR, referral to hospice. So anytime you know you're moving in that direction, bring us in. It doesn't mean we're going to come in and talk to that family or take over a case or anything like that. It means we're going to be part of the care team at that point to know that that is one possibility. Because again, once that extubation happens, we've lost that window. And we don't expect families to think of it in that moment. I always say we have a volunteer who speaks for us sometimes who wasn't asked. Her young teenage son had died and was guilt-ridden when she realized later that nobody asked her about donation. This was years ago, I will say that. But in the moment, families aren't going to think about it. So we always like to say, find a little pause where in your system, and I think that you guys actually have that for us, is like stop and has LifeLink been involved? Do we know if this patient's a candidate or not?
What is the first person authorization law and how does it relate to organ donation?
So perfect question. Again, fits into all of this. So Georgia and really every state now is a first person authorization state, which means that your wishes that you made while you were alive precede anything else. We're talking about kind of legal healthcare decision makers and all of that. If you are on the Georgia registry, that is authorization to move forward with donation. And I use the word authorization because donation falls in a sort of different category. It actually falls under consent law when you're talking about the legal aspect of it. And so it is authorization. If your body is your possession, is the way that it's seen by law. And so you have the right to decide. It's almost like how you would treat your belongings in a will, if you will. But the reason that is because then you can make that decision in advance and your family doesn't have to struggle. You don't have to find the right person. That is the decision. It is legally binding, I will say. I know that there are cases where we've gotten ethics involved. More often than not, what it does is takes the decision off the family. And it's usually a relief. Okay, he was on the registry. Great, what happens next? If the family does bring up an opposition, then we will get ethics involved and anybody else that's on the care team and kind of work through where is the opposition coming from. Sometimes the opposition is coming from everything has been spinning out of control. I haven't gotten to choose anything and now here's this, right? And then if we can talk them through that, then sometimes the family will be okay and we'll be able to move forward. Our intent is to move forward and honor that patient's wishes. We are legally bound to do that so we can actually be held liable if we don't. That said, there are scenarios where we know that that's not going to be the right decision. We try to make those in between. Yeah.
Mark Young, I'm one of the trauma surgeons. I haven't run into a situation here, but in the past, we've had patients who were anticipating families going to pursue organ donation. And so the organ donation team is on site and speaking with the family. And I've been asked to perform invasive procedures such as bronchs and VALs before they transition care to organ donation team. I'm just wondering, how does that work? So from my perspective, until that transition happens, these are medically unnecessary procedures for my care. And I get that it speeds up the process because they need to be done before the donation process. So that's one part is, where do we send? Do we perform procedures? And secondly, then is billing. Does that bill go towards the family because they haven't transitioned care to organ donation? Or is that bill go to you all?
Those are both great questions. So it is billed to us. If we've asked for it, we pay for it. So anything, we get the bill generally before it even goes to the insurance company or anything like that. And we go through line by line and try to be very careful in taking off any charges that we have created. If the length of stay is continued because of that, we're picking up that day of care. So whatever it might be. As far as invasive procedures and things like that, it does sort of depend on where we are with authorization to an extent. So if patients on the registry, that's sort of that's a authorization then to do those procedures as well. If the family's interested in donation, then we want to do that if it's to preserve the opportunity. If it's something that can wait until after, say, brain death testing, and then that's more appropriate time, that might be okay. You guys, if you've been involved in our cases, you know that they're very long, and they haven't gotten shorter. So we do want to move things along as best we can for you and for the family, of course. The secondary piece of that, if you're uncomfortable about feeling it, there is in the CMS conditions of participation a clause that says that the care team has a responsibility to do medical interventions to maintain the opportunity of donation. So, I don't think you should feel like it's unethical to do it necessarily. If you've got a family standing there saying, we don't want this, that's a whole different thing. And obviously, we can get ethics involved as necessary or wait as appropriate.
And how does this change for minors? Like donation, I know if they're 16 and up, they have a driver's license, they have that option, but for trauma, we can start at 15. They may have awareness if you're not ready.
Yeah, no, still 16 for us. Yeah.
So how is that handled differently?
So under 16, always is going to be an authorization. And so we will talk to the family. There's no first person. Like if they're 15 and they've gone in and gotten their learner's permit, that's not going to change, that we still need authorization.
Is it book here? Like how does that process? Like if you have a child that, the third grade did, right? How do both parents have to agree? What happens if there's a disagreement? What parents are more first or extended? They have that.
So generally it's authorization at a level of kinship. Right. So if both parents are involved. Now, if there's a legal arrangement in a divorce situation or whatever it might be, then that might supersede it. But yes, generally, if it's two parents that are at the bedside and one disagrees, then we would not be able to move forward. But again, that's when we get our family care coordinators involved and kind of work through where the opposition is coming from, particularly in kids and trauma. If you think about this is somebody who was doing their normal thing maybe hours ago, certainly maybe a day or two ago. And sometimes it's just a more issue of let's process through this. Let me get to that understanding and making sure we bring donation up at the right point. If we introduce donation too early, then they're absolutely saying, I'm not ready to talk about this. I'm not ready to give up or to be in that state. And so you were talking about cues earlier from the family on which way they might be going, what their priorities are. We have a tool that we call a family readiness assessment, and we use that to determine, in conjunction with you guys, we would not talk to a family without the care team knowing that was our intent, but are they ready to hear this?
Are you able as a donor to decide what you want to donate and what you do not want to donate? And where would you put that in writing?
So, correct. When you go to the driver's license office, the DMV, DDS, what's it called? DDS. That's generally how most people get into the state registry. But you can go to the website and you can get there from donatelifegeorgia.org. And then you can go into your individual registry and you can say, I want to donate my liver but not my heart, or I didn't know corneas, or whatever it might be. You can do your research intent there as well. So if you want only for transplant but not for research, you could put it there. Most people don't know that. That's a good question. Yeah.
Yeah, that's a good question.
Watching the driver's license signification, on the bottom. What if a person says they want that? They go to have their license renewed and they remove that. Is it removed from the registry? Yes. Okay.
So we get sort of an upload every few weeks, and that's when all that sort of level setting happens. So we've also even had a situation where somebody had just gone in the last few days, and we went to look for them. They weren't on the registry, and then we got their license, and when we talked to the family, they're like, oh yeah, that just happened. And the reverse may be true. So there could be somebody who put themselves on the registry, and last week we had a family reunion, and he said he didn't want to do it. That's when, again, you have to put a little grace and trust into the family and make decisions based on what you have in front of you.
So it is 9:02. I want to be respectful of everybody's time. So thank you for coming to Trauma Grand Rounds. If you want to ask any more questions, they'll be here for just a moment. But thank you guys so much for coming.